Hey folks, my name is Scott Weingart, and this is the EMCrit Podcast. The EMCrit Podcast is a bi-weekly show on emergency medicine, critical care, and resuscitation. Now, the folks at Cheetah Medical, manufacturers of the Nikon device, asked me if they could reproduce a podcast I did with Dr. Marik on the issue of fluid responsiveness. And whenever I get asked things like this, I'm kind of torn because the EMCrit Podcast has no commercial affiliations at all, and I take no money from any company, nor does Dr. Marik. But the folks at Cheetah Medical are a great bunch, and I actually like their product, so I figured why not let them reproduce the podcast. But just so we're absolutely clear, I've taken no money for this reproduction. I have no commercial affiliation whatsoever with the Cheetah Medical folks or the Nikon product. Everything you hear is solely the opinions of Dr. Marik and myself. If you like what you hear, then come on back and check out the other episodes of the podcast at EMCrit.org. All right, enough of that. Let's get to the podcast. Hey folks, we are extraordinarily lucky today to be joined by a guest that I've wanted on the podcast for a long time, and some of you folks have requested him as well. So let's hear from our guest.
Hi, my name's Merrick. I'm an intensivist and the chief of Pulmonary Critical Care Medicine at Eastern Virginia Medical School.
Fantastic. We're so lucky to have you here on the podcast to talk about a subject I think is near and dear to your heart, fluid responsiveness. So why don't you tell us what fluid responsiveness is?
Yeah, so I think that's a good question because unless we all know what we're talking about, we're going to be at cross purposes. So I think it's important to have a working definition so we all use the same definition. So what we basically come down to is fluid responsiveness is if someone will increase their stroke volume by at least 10 or 15% after a 500 cc challenge of a crystalloid over 10 to 15 minutes. So I think that's a very good working definition of fluid responsiveness.
So let's make sure we're all on the same page here. What we're going to be talking about today is the topic of fluid responsiveness, one of the toughest questions in critical care, whether that be in the ED or the ICU. And the definition we're going to be working with is if you gave a patient fluid, will they increase their stroke volume by 10 to 15%? Stroke volume is how much with each beat of the heart that heart ejects, whether it be from the LV or the RV. And the idea is if you gave a patient fluid and their stroke volume increased, meaning their cardiac output increased, meaning they're getting more perfusion to the tissues, that is a good thing. If you give fluid and there's no increase in stroke volume, then that was a wasted bolus of fluid and the patient really didn't need it. And the definition we're using is if you gave the patient 500 cc's of crystalloid over a rapid period of time, 10 to 15 minutes, meaning you really need to use a pressure bag, did their stroke volume increase by 10 to 15% of its baseline before the fluid was given? If you don't understand any of that, then the rest of this probably isn't going to make sense. So go back or send me an email. Now, when I was practicing in the ICU, this was one of the hardest questions to answer on a critically ill patient. Would you agree with that?
Yeah, I think up until now it actually has been almost an impossible question to solve or answer, but I think we've been using the wrong tools. And I think with time, our understanding has improved. We have better tools. So I think finally, we've opened the closet. We've opened we have the combination to Fort Knox, and now have some answers.
Now, if I had a guess, I'd say the tool you were most happy with is the central venous pressure, correct?
Yeah, so basically that's all we do. We measure the CVP, we monitor it precisely, actually on an ongoing basis, and the nurses call me day and night with the CVP.
Now, all joking aside, I would say your 7 Mares article put the final nail in the coffin of CVP as an assessment of fluid responsiveness. How'd that come about?
Actually, we're up to 17 Mares now, so the wonderful thing about science, which people kind of forget, is that, it's not one person's observation. If it's a valid observation, it's as valid as it is in Timbuktu as it is in New York. So it's reproducible. So I think now there are probably over 100 studies that have shown unequivocally that the central venous pressure cannot predict volume responsiveness and cannot tell you about intravascular volume. And indeed, there are only 2 papers in the entire universe of the literature, so this is within our solar system and beyond, that actually show that the CVP may be of some value. And both of those studies actually were in standing horses. The first was in 7 standing mares, in which they venisected the patients. The second actually was in 10 standing horses when they volume depleted them. And those 2 studies stand alone as the only studies in the entire world literature that actually supports using the CVP. And I'm not sure if it has to do with the horse and the long neck or what it is. So from my perspective, if you follow any kind of scientific logic, unless you have a standing horse in your ICU, you really have no business measuring the CVP.
Absolutely. If you already have a central line in, do you even bother hooking it up for the data, or is there no purpose to it at all?
No, it's an absolute total waste of time. What it does do is it provides people with false information on which they made bad decisions. So it's best that it's hidden, it's banned. So in our ICU, we prohibit anyone actually even discussing it. It's a forbidden word, and no one's allowed to measure the CVP.
Fair enough. So CVP is out. You have a patient with signs of poor perfusion, and we need to know if fluid is going to be of benefit. So what are some options to talk about fluid responsiveness in this patient? What about clinical exam?
Yeah, so I think there's good data showing that clinical exam is useless. So there's really good data looking at the ability of clinical exam to predict a whole host of hemodynamic variables, and it's really no better than flipping a coin. And we should add to that the chest X-ray, or the change in the chest X-ray, interpreted by expert radiologists, again, totally unable to predict volume status. So unfortunately, clinical exam, chest radiography has unfortunately no value in assessing volume responsiveness.
All right, let's talk about some things that do putatively in the literature work. How about pulse pressure variation?
Yeah, so pulse pressure variation is interesting, and we previously published a paper showing that there was quite good predictive value. Since then, I think we've learned a little bit more. So just to put it in perspective, most of the studies that have been done on pulse pressure variation were done in the operating room or in surgical patients post-surgery. So it's a very narrow population of patients in a very controlled environment in the operating room. And obviously these patients are all heavily sedated and receiving volume control ventilation. So within that context, it appears that pulse pressure variation does have some predictive value. However, I should add a caveat that there's recently a paper by Maxime Cannison, which is a really good paper. This is a multi-center paper, and basically the bottom line is that even in the operating room setting, that if your pulse pressure is somewhere between 9 and 13, it becomes impossible to predict volume responsiveness. So if you're at either extreme, you have a very low pulse pressure variation or a high pulse pressure variation, then that's likely to be helpful. And then obviously there's other caveats. So you need to be on a ventilator, you need to be on a fixed tidal volume, you need to be in sinus rhythm, you need to have compliant lungs, and you need not to have RV dysfunction. So that obviously is a lot of caveats, which often don't apply if you're in the emergency room or in the ICU. So I think that we're kind of recognizing that in the real world that we live in, pulse pressure variation is less valuable. I think maybe as an adjunct in some patients, but as your primary tool to assess volume responsiveness, I think there are too many limitations.
All right, let's recap so far. Dr. Marik was one of the authors of a paper called The Seven Mayors, a systematic review of CVP for the purposes of fluid responsiveness. He was the first author. He pretty much put the final nail in the coffin for CVP. And I will put that article in the show notes, of course. So CVP, in Dr. Marik's opinion and in mine, probably not so great. Clinical exam doesn't work. What looked promising for a time was pulse pressure variation or stroke volume variation. And the idea behind that is if you have a patient on mechanical ventilation and they get a breath, that's going to affect their venous return first to the right heart and then a few beats later into the left heart. And that will therefore change the stroke volume because of the venous return effects, and therefore will be a predictor of whether the patient is volume responsive. If you are well loaded in your fluid status, then those mechanical breaths are going to have less effect than if you were not volume loaded. So that's the idea behind it. Problem is you need a patient in sinus rhythm, you need a patient with a normal right heart, you need a patient on mechanical ventilation. And I actually increased my tidal volume to 10 cc's per kg. A lot of the work was done with that setting, which is what most patients in the operating rooms are getting, as opposed to the low tidal volume strategies, which I recommend on all critically ill patients. So I actually temporarily increased that for the purposes of looking at the pulse pressure variation, and then drop it back down. And from what I'm hearing from Dr. Marik right now, it's probably not great in the rapidly changing environment of the critical care unit or in the ED-ICU. So not a great way to go. What else is out there? Well, one of the things we've been doing for our New York Sepsis Collaborative is recommending IVC Collapse in a spontaneously breathing patient or IVC expansion in a mechanically ventilated patient. What do you think about that?
So, I think that if you don't have any other better tool, if you don't have a phone, you're going to use smoke signals. But I think, technology has advanced. And, we actually have a setup now where we do a whole host of maneuvers to look at volume responsiveness. And we found that in gross circumstances, it's helpful. So if a patient's clearly volume depleted, you're going to see quite marked variation. But in the patients that are somewhat in the gray zone, it's not helpful. So if it's the best you have, then, it's the best you have. But I think it's not the ideal tool. I think it's very operator dependent. I think there are lots of factors that affect IVC variability. So, we look at it as, it's an amusing thing to look at, but we don't base therapy upon it.
Well, what if you took that ultrasound probe and moved to the heart? Are there any echocardiographic factors that'll let you know if the patient's going to be fluid responsive?
Yeah, so, I think echocardiography is central to your management of any hemodynamically compromised patient. So, I think it's part, I don't think one tool gives you the answer. And I think any good craftsman has multiple tools in his toolbox. So I think an echo is really helpful in telling you about LV function. In terms of fluid responsiveness, it's again less helpful. It may be helpful in patients who are grossly hyperdynamic, who have an obvious empty LV. But otherwise, I think it's not helpful. There's a misconception that actually if you have a dilated heart and you have systolic heart failure, that you cannot be fluid responsive. And that's absolutely incorrect. That what we do is we fluid challenge our patients with heart failure, and believe it or not, some of them actually are fluid responders. So the fact they have a dilated LV doesn't mean that they're a non-responder.
Fair enough. Now, we've talked about a lot of things that don't work fantastically. Let's talk about what you're currently recommending. I was lucky enough to get to read a advanced copy of an article that's coming out in Resuscitation that you authored, and you seem to advocate the best way to answer the question, will the patient respond to a fluid bolus, is to actually see if the patient will respond to a fluid bolus. And you've outlined two ways to make that happen. Why don't we talk about passive leg raising first?
Yes, it's not rocket science. Rather than, infer the the shape of an object by looking at its shadow. Why don't you just look at the object? So, is the patient fluid responsive? Give them fluid and see what happens. It's not rocket science. So you can do this directly by giving them fluid. And, I think most patients can actually tolerate a 500 cc challenge. It's not going to kill them. It's the size of a Diet Coke. And I'm not aware of any literature of a Diet Coke killing anyone. In those few patients who actually may be in pulmonary edema, in whom you're concerned about the fluid, then what you can do is lift the legs. And I think if you do a passive leg raising in a very standardized way, it's very useful. And I think it's important that it has to be done properly. So we find it a very useful tool in terms of predicting volume responsiveness. And obviously, it can be done in a non-intubated patient that can be in any rhythm, excluding asystole. So, what you do is you start off getting a baseline measurement with them sitting up. So the legs they're lying in bed with their head up at 45 degrees. You get a baseline level. You then lift their legs up to 45 degrees while putting the head of the bed flat. So they're now vertical. And what you do is you get an instantaneous transfusion of blood. And really within 1 to 2 minutes, if you're a volume responder, the stroke volume goes up. And really most patients, it's pretty clear they either respond or they don't respond. There are a few in the gray area. And data shows that it has highly predictive reliability and is highly reproducible. So that's really a useful technique. The other, as I said, is just give them a fluid bolus and see what happens. Obviously, the question comes is how do you measure the change in stroke volume? And I think clinical signs don't have the fidelity to measure that. So you can't look at blood pressure or pulse rate or any other clinical sign. What you have to do is look at change in stroke volume. It's pretty obvious. The method we use currently, which we've actually gained a lot of experience, is using bioreactance. It's totally non-invasive. It's an improvement of what was previously bioimpedance. It's similar in principle, but it's the newer, upgraded kind of understanding. So with bioimpedance, you would put stickies on the chest, you would inject electromagnetic current. The sensors will then receive the current, and then by looking at the change in amplitude of the wave, you would infer that was due to movement of blood or change in volume of blood in the aorta, and that was stroke volume. The problem is it was affected by body shape, by obesity, by pulmonary edema, and by the distance between the electrodes. Bioreactance, again, you have two sets of electrodes, so you put on either side of the body, just below the clavicles, and then just at the bottom of the chest. And the two outer electrodes basically transmit the signal. The two inner electrodes receive the signal. And what this does, instead of looking at change in the amplitude of the wave, looks at what's called the phase shift, which is something to do with like the change in frequency. So it's much like a Doppler signal where you inject ultrasound into moving blood and then bounces off, and the returning signal is changed according to the rate of flow of blood. So this is called bioreactance. It has numerous advantages over bioimpedance, mostly that it's accurate, whereas bioimpedance really didn't perform well in critically ill patients. Secondly is that it's not dependent on the distance between the electrodes, so you really don't need to measure the distance. And there have been a whole host of studies that show that it's pretty accurate, and obviously depends upon the gold standard, but actually in animal models where you actually put Doppler rings around the aortopulmonary artery, it's been shown to be extremely accurate in measuring cardiac output.
I see. Now, this is the Nikon monitor you're using.
Yes.
And
yep.
I've been trialing it as well. I've been pretty happy. My question to you is, a lot of these monitors, especially the non-calibrated pulse contour monitors, when the patient starts crashing and their vitals are changing rapidly, they become random number generators. What's been your experience with the Nikon monitor?
Yeah, so I agree with you. I think some of these machines are no better than random number generators, so you have to be really careful. I think that Nikon is pretty accurate. Obviously, at the extremes, particularly patients who, extremely hypotensive with very poor low cardiac output and maybe hyperventilating, it sometimes is difficult for it to pick up a signal. But we've actually found it to be extremely useful in predicting volume responsiveness. We're kind of doing a pilot study where we're looking at a whole host, 6 or 7 different variables simultaneously, and we found that it's pretty accurate. It's amongst the best predictors. What's nice about it is that it's totally non-invasive. Patients don't need to be intubated. You can do it in patients in atrial fibrillation. And you can start off doing it in the ER. So we have a progression. Our ER folks have really liked this technology. So we start resuscitating them in the ER, and then with the same technology, we progress to the ICU. And in fact, there's been a whole paradigm shift. So the nurse or resident will call me and say, "Hey, Dr. Marik, Mrs. Jones was admitted. We put on the Nikon, and she's fluid responsive or she's not fluid responsive." So the whole language has changed. So people now talk about fluid responsiveness as much as they talk about blood pressure or pulse, which I think is a monumental shift in the way we manage patients.
I love that. Now, let's say you had to make a recommendation to someone who didn't have any ability to monitor cardiac output or stroke volume. What should they be doing?
Yeah, so that's a difficult question. So, obviously, we're talking, and this is not high-end technology, and, I think even countries that aren't as wealthy as the U.S., if you have an intensive care unit, I think these units are becoming affordable. But, if you're in the boonies, I would say, use basic principles. Don't use the CVP. I think that the first step in resuscitation is always giving a patient fluid. So I think if your hands are tied, you need to give fluid and see what they do. One of the problems that came out of early goal-directed therapy from Manny Rivers et al. Is people said, well, okay, you need 6 liters in the first 6 hours and 11 liters in 24 hours, so that's what I'm going to do. And in fact, there are studies published which people try to reach those goals. And obviously, I think that's incredibly naive and cognitively somewhat impaired, because clearly every patient is different, their needs are different, and you can't, it's not one formula fits all. So, you have to individualize your resuscitation for each patient. So, what I would say is if you have no technology, I think having an ultrasound should be available anywhere. This is really very cheap technology which should be universally available. Do an echo. At least an echo, you can look at the heart and you can look at IVC diameter and variability. So that may be a starting point. But I think if you have critically ill patients, you really want to get them to a center that can, manage these kind of patients.
I can't agree with you more. Dr. Merrick, thank you so much for coming on the podcast. People are going to love hearing this episode.
Oh, that's a pleasure, and it was great speaking with you. And, I think this is an ongoing topic that's, evolving with time, and I think one has to keep an open mind.
That, folks, was Dr. Paul Marik. Amazing, amazing stuff. So what does it come down to? Well, according to Dr. Marik, and I think I have to agree, if you're taking care of really sick patients, whether they be in the ED or in the ICU, you need some way to monitor cardiac output, whether that means the Nikon monitor we were talking about, or one of the more extensive monitors, or if you get very good with ultrasound and learn how to use the aortic outflow tract to actually get a consistent cardiac output measurement. you need some way to do it, because that's probably the best way to find out if the patient's fluid responsive. Actually give them fluid, whether it be by passive leg raise or by actually giving them a fluid bolus and seeing what it does to their stroke volume. If their stroke volume increases, they're fluid responsive. Try again. If it doesn't, they're not. And recheck that in a few hours to see if the patient's physiology has changed. But for now, they are not fluid responsive. Neither Dr. Marik nor myself have any conflicts of interest. We're not taking money from any of the companies we mentioned. This is just our own opinions, as always. Scott Weingart for the EMCrit Podcast, saying bye-bye.